We'll wait another minute or so for people to join. I think we had about 33 people RSVP for this, so we'll wait a couple more minutes. Hey everyone coming in, this is Caitlin Mills with KOSU Radio. We're just waiting a couple more minutes to get started. Waiting for some more people to join. We had about 33 people RSVP, I think. Okay, I think we can go ahead and get started. Hi everyone, this is Caitlin Mills. I'm the Engagement and Special Projects Reporter for KOSU. We're starting this Twitter Space conversation about reproductive rights on reservation land, and we have a great panel for you today. Also, this is our first one, so we're learning all of it as we go. It'll be fun. And we know that you guys may have a lot of questions during this, and we also may know we might not be able to answer all of them at this moment, but we wanted to at least start this conversation today. And just so you guys know, we will be recording this conversation. So now I'm going to take a few minutes to go over some of our room rules. The first one is please be respectful of our speakers and of each other. Please do not talk over each other. And please refrain from using any harmful or derogatory language. And if you cannot mind any of those three, we will remove you from the room. Also, Isla cannot give individuals legal advice. So, okay, so we will be taking speaker questions a little bit later during this. So please feel free to hit that request button. It should be in the bottom left-hand corner. And either myself or Ryan LaCroix will bring you up when we have a chance to do that. So for now, I'm going to just introduce our speakers today. Isla Haas is an assistant professor of law at the University of Tulsa College of Law, where she teaches and researches at the intersection of Indian law and health law. Professor Haas practiced public health law as a staff attorney with the Center for Disease Control and Prevention's Public Health Law program. Catherine Sweeney covers health for State Impact Oklahoma. She has covered politics and policy in Colorado's High Plains, Oklahoma City, and Washington, D.C. Catherine has been covering Oklahoma's abortion laws in depth and was recently featured on the NPR Politics podcast about this topic. And Allison Herrera covers Indigenous Affairs for KOSU. She previously worked for PRX's The World, and she's been a reproductive rights fellow in the International Women in Media Fund. So we'll go ahead and get started, and I'll kick it over to Allison to get the conversation started.
Well, thanks for joining us, everybody, today. I know that all of you have a lot of questions, and I'm just going to reiterate what Caitlin said earlier, that we may not have all of the answers, but this is just a beginning of a conversation. And so if there is something that you want answered that we can't, if there is something that you ask that we can't answer today during this Twitter Spaces, we will follow up with you. I think the first thing I'd like to do is just get ask Catherine and just ask her to establish what are the current laws around abortion in Oklahoma that were recently passed, and specifically the trigger laws.
Right. So we have a few laws on the books that just say if the Supreme Court overturns Roe v. Wade, abortion is illegal in Oklahoma. We've passed those in the past. We've passed them recently. But more recently, we have passed two laws that restrict abortions. So The first one that has already gone into effect because Governor Stitt signed it, and it went into effect as soon as the governor signed it. That's Senate Bill 1503. It's a copycat of Texas law. Theirs was Senate Bill 8, and it went into effect in September of 2021. It is different from most abortion laws across the country because it relies on private citizens for enforcement. Instead of saying, you have to pay fines to the government or you have to pay, you know, different things like that. Anybody who was found by a civil court to be supporting an abortion, performing one, they would be subject to $10,000 in damages to the person who sued them. So, that the Supreme Court, federal court, has not overturned that law in Texas. Supporters of 1503 are hopeful that the court would also not overturn this Oklahoma law. So that was signed in the past few weeks. Governor Stitt has not yet, oh, wait, he has signed. Governor Stitt signed Senate Bill 612. That one criminalizes abortion. It would make performing an abortion, not getting one, but performing one, a felony punishable by up to 10 years in prison. Stitt did sign that bill, but it did not have the same kind of emergency clause, so it is not in effect the way that 1503 is already in effect. So that's kind of the landscape of abortion that Oklahoma has right now.
Okay. And so, one of them, let's just be clear, one of the laws took place last week, and then the other one is a trigger law, correct?
Oh no, Senate Bill 612 is it's not a trigger law, but
Okay.
it just hasn't gone into effect because it didn't have it didn't have an emergency clause that made it take effect immediately. So it'll go into effect at the end of the summer unless it's overturned, which there are legal challenges to both of these laws by Planned Parenthood Great Plains and a few other abortion rights advocacy groups, as well as abortion providers in Oklahoma.
Thank you for clarifying that.
Yeah.
So I want to just get to one of the big question that a lot of people have weighed in on Twitter, and then also that I've talked with several people I think that are in this room about Indian Health Service providing abortion. And how that affects, tribally run clinics, and specifically with the Hyde Amendment. And so I'd like to bring in Isla Haas to talk about this. So the Hyde Amendment was passed in 1970, in the late 70s, and took effect in 1980. And basically, it is a federal law that prohibits use of federal funds for abortion care, for providing abortions. And Indian Health Service does receives federal funds, and so is included in the Hyde Amendment. And I think for just to begin this discussion, Indigenous women have. I've written about this. Who experience sexual violence, find very little support at Indian health facilities. To be able to receive this kind of care, even though the Hyde Amendment does allow for some exceptions in the case of rape or incest and when a woman's life is in danger. And so Isla Haas is the expert here on this, and so I'd like to bring her in and just ask her, with the current, abortion laws that Catherine just described here in Oklahoma, how would they affect tribally run clinics?
Yeah, so I think just for a little bit of background for listeners who aren't familiar, the federal government's obligated to provide health care in Indian country based on treaties, statutes, and the trust responsibility. And the framework in which it does is what's called in shorthand the ITU system. So, I being Indian Health Service, government agency providing direct care, T referring to tribal 638 facilities. So, those are federally funded under a contract or compact with the federal government. And then finally, urban Indian health facilities. And so the Hyde Amendment's prohibition of using funds that are appropriated to the Department of Health and Human Services is includes the umbrella of not just Indian Health Service direct care, but also tribally operated urban Indian health facility operated 638 facilities. So, irregardless of what might be happening on the ground at the state level, this limitation is still going to be in effect in the context of how federal funds are going to be used. Now, you and others have studied and commented that even within the context of these exceptions, performing abortions at ITU facilities is incredibly rare, and there's a lot of inconsistencies in terms of the policies to allow for providing abortion care at these facilities at the local facility level. On top of this, what's important to understand is that the Hyde Amendment is about limiting how federal funds are being used. And so that doesn't necessarily prohibit a tribal facility from providing this kind of care if they are segregating their funds and using non-federal sources. And so there's a parallel to that at the state level in the context of state Medicaid programs. So even though the Hyde Amendment is going to apply to federal funds that are distributed to states to support their Medicaid programs, states could use their own funds to be able to provide that kind of coverage. And several states have opted to do so. And so that is also a tool that a tribe could use in terms of segregating their funds and getting out of the Hyde Amendment prohibition.
I just wanted to ask too, you mentioned a 638 tribal facility. Maybe not everybody on this spaces knows what a 638 the tribal facility. Can you just explain what exactly that is?
Yeah, so 638 is shorthand for Public Law 638. So Congress, through the Indian Self-Determination and Education Assistance Act, passed a law in the 70s to facilitate tribes to self-govern their own programs, not just health programs, but other kinds of programs like education. And so the idea is that money that would have otherwise gone to Indian Health Service direct care can be funneled instead to tribes through a 638 contract or compact, and they would have more flexibility in the types of day-to-day decisions in the operation of the facility. And overwhelmingly, particularly in the context of healthcare, 638 facilities have seen an abundance of success, improved health access, and improved health outcomes in many communities.
I wanted to ask. So this is a question that I asked you in the middle in the middle of April when I wrote the article about will tribal lands provide safe haven when Oklahoma's abortion ban goes into effect, and your answer to me was basically that it's complicated, and I think it's complicated for a number of reasons. When we talk about the McGirt decision of applying, let's say to the city of Tulsa or to say to the city of Tahlequah when a doctor who is not accepting any funds from the federal government decided to open up a clinic that would provide reproductive care, abortion being one of those things. It's not just so cut and dry. It doesn't. It's not just that this person could just say, "Well, I am, I can't be prosecuted under state law because of McGirt, and therefore I'm going to open up this clinic." And I wondered if you could just talk about why that is.
Sure thing. My shorthand for that answer now is this idea of a safe haven in Indian country to provide abortion care is not going to happen without a lot of lawyering. So again, for folks that might be less familiar, when we're talking about jurisdiction, we're going to be either considering criminal jurisdiction or civil jurisdiction. And so basically, if it's not criminal jurisdiction involving a crime, felony or misdemeanor, then everything else is going to be under the purview of civil jurisdiction. And so conveniently, a product of history, colonization, racism, federal Indian law, the field of law that governs the rights, relationships, and responsibilities between tribes, states, and the federal government has created different frameworks in which to determine who's going to have criminal jurisdiction based on a certain set of facts, who's going to have civil jurisdiction based on a certain set of facts. The primary inquiries to start off with when we're thinking about criminal jurisdiction is the location of the party or the location of the conduct. So generally that's considered really broadly to be the outer boundaries of the reservation. And then the identity of the victim, the identity of defendant, and the type of crime that's involved. So just within the purview of criminal jurisdiction, we are going to have to think about whether we are dealing with an Indian defendant versus non-Indian defendant. And so in the context of an Indian defendant, and I say Indian, that's the legal term under federal law, that is defines a person to then be subject for criminal jurisdiction in Indian country. So if we're talking about an Indian defendant, regardless of the status of the victim, whether non-Indian, Indian, or victimless, in general, the state is not going to have jurisdiction. And then depending on the type of crime, there could be, and the identity of the victim, concurrent federal tribal jurisdiction. And so that's when we have, so in the context of Oklahoma Senate Bill 612, a criminal statute that criminalizes the provider. So you're going to have an Indian healthcare provider who's the defendant being charged for violating that crime. And so there's just really not a lot of avenues in that context for which the state could be able to assert jurisdiction. Now, that analysis is going to look different if we've got, let's say, a non-Indian provider. And interestingly, as Professor Stacy Leeds and others have commented on, there could be an issue of whether Oklahoma law can assimilate into federal law. And so
that's called the Assimilative Crimes Act, correct?
That's right. So the Assimilative Crimes Act. So even in this, if we're looking at an Indian healthcare provider wanting to provide an abortion care within the outer boundaries of the reservation, and even though the state would not be able to assert jurisdiction regardless of the status of the victim, the Assimilative Crimes Act allows for essentially what we call the assimilation, the borrowing of a state statute in circumstances when there isn't a corresponding federal statute. Now, the Assimilative Crimes Act is really limited in that if it's going to be used in the context of the Major Crimes Act, and so that was the one of two federal legislative pieces of legislation that govern criminal jurisdiction in Indian country, it's really limited in that you could only assimilate crimes that are already enumerated under the Major Crimes Act, but there isn't a corresponding federal statute. And so that comes into play mostly in the context of burglary and child neglect. And so, although I'm sure there would be other folks that would say that this is up for discussion, this providing an abortion would not necessarily fall under the Major Crimes Act. And so it would have to be charged under the other federal legislation, Indian Country Crimes Act. And so the Indian Country Crimes Act, also called the General Crimes Act, Interracial Crimes Act, applies for non-major crimes. And so the Assimilative Crimes Act is a tool for non-major crimes that aren't going to be outlined in federal law to assimilate the state law. It's just not used very frequently, and I feel like personally that it would be really unrealistic for at least the current administration in the context of kind of getting through post-McGirt related cases and kind of getting up to caught up in terms of caseload, that the DOJ would be prosecuting this particular Oklahoma statute, even if there was an argument for assimilating it.
I want to also just talk about licensing too. And first, before I ask you that question, Isla, I'd like to ask Catherine, so now that we have the law that just went into effect, it's basically that nobody can get a license to what was the licensing process like before this law went into effect, and now and I guess I'm just speculating that now getting a license to perform abortions in the state is non-existent.
Right. So Oklahoma has passed a few laws or considered a few laws that kind of restrict which doctors can perform abortions and how. A lot of laws have tried to say that it should be only OBGYNs or they have to have admitting privileges, but um, doctors are still getting trained on performing abortions. To my knowledge, I know that Planned Parenthood Great Plains talked about how they're still continuing to train doctors. One thing that I'm going to point out is that we do, even under these laws, we will still have doctors who can perform abortions because 1503 allows them up until 6 weeks. So, although most patients won't know they're pregnant within 6 weeks, or they might not, because that would only be a couple weeks within of a missed period. That can take place. There are also carve outs for life threatening emergencies. So, if there is an ectopic pregnancy, which would kill the patient who's pregnant, or any other kind of medical emergency that could kill the person who needs an abortion, there would still be very few and very narrow circumstances under which abortions could be performed in Oklahoma under 1503. Um, so there will still be some training, and there will still be some allowed, but there are concerns that these kinds of limitations will mean significantly fewer doctors who are capable of performing these kind of more difficult abortions. And in that case, if there are situations where it is life threatening, there could be a limitation on the number of doctors available to provide those services.
And that gets even more complicated when we're talking about doctors who may want to get a license to provide this kind of abortion care. Um, you know, Isla, we talked a little bit about that licensing issue when I spoke to you about a month ago. Can you expand on what Catherine was saying in terms of just in terms of our discussion about McGirt applying, within the reservation, when if an indigenous doctor decided that they were going to provide this service, however unlikely that may be.
Yeah. So basically, as I had said, outside of criminal jurisdiction, everything else would fall under civil jurisdiction. So that would be licensing of healthcare providers, liability for, let's say, malpractice for a healthcare provider. Um, and the Oklahoma Senate Bill 1503 is an example of a civil related abortion law. And so when we are thinking about civil jurisdiction, I will often tell my students that you have to think about it in three ways. One, whether federal law is going to apply on reservation. Is federal law, whether and the test might be different in terms of whether the law is specific to Indian country or it's a law of general applicability, and whether it's going to apply in Indian country. Two, when a tribe can assert jurisdiction over a non-member on non-member fee lands within the boundaries of the reservation. I am non-native and I own a home in Tulsa, and so when can the Muscogee Nation Reservation assert civil jurisdiction over me? And then third, when can the arm of the state extend within the boundaries of the reservation, particularly in the context of a tribal member? And so each of those tests are different. And even within those silos of our test, they can be really complicated and unpredictable. And so, for example, applying Oklahoma Senate Bill 1503 would need an analysis of whether that enforcement of the state civil law would interfere with the unique federal tribal relationship, whether applying 1503 on reservation, particularly against a member, would interfere with tribal sovereignty. And the courts will often implement or utilize a balancing test in order to weigh a state's interest in that case versus tribal interest and as applicable federal interests that come into play. That analysis can be really unpredictable. And we've got examples where courts have come out on both sides in terms of allowing state jurisdiction or not. So the other layer of this that becomes complicated is what you mentioned, Allison, in terms of licensing. So if a provider who's a tribal member and wants to both avoid criminal penalty and be able to avoid any Hyde Amendment issues, they're going to either be having to provide that care within the context of a tribal facility or independently. But there's also issues that come up in terms of both licensing and liability for the provider. So, for example, within the construct of a tribal 638 contract, a provider, based because of federal law, doesn't necessarily have to be licensed in, let's say, Oklahoma for a 638 facility that's located within the boundaries of the state, because federal law says as long as that provider is licensed somewhere, that's sufficient. Federal law also provides liability protection, tort liability protection for providers providing care within the ITU facilities, so long as it's within the scope of the 638 contract. And so providing care outside of that contract and outside of federal funds opens up the door for whether state licensing is going to apply, whether just tort liability, medical malpractice liability is going to apply. There's also the issue of, well, where is that provider going to be licensed? And are there risks even outside of, let's say, medical malpractice or outside of 1503 that a provider could lose their license? So, for example, Oklahoma's medical licensing provisions allow for a provider to get disciplined for unprofessional or unethical conduct, and includes language of violating, even without conviction, a criminal law, even if I'm recalling as broadly of a criminal law that applies in another state. And so a provider could also be subject to discipline, if not potentially losing their license, or even potentially privileges at a facility because of the care that they're providing. And so there's just a lot of considerations on the civil side as well in terms of being able to provide this abortion care, even if you're a member, even if you're on reservation.
Thank you for that. I think I want to ask just one more question of Catherine, and then then we'll turn it over for questions. Catherine, when I wanted to, you and I had a discussion a few weeks ago about gender affirming care, and I wanted to know if any of the current laws on Oklahoma will affect gender affirming care. I think we're still looking into this, but I wanted to know if any of the laws will impact that.
So I have not dug into that as much as I would like to by now, but I do know that we haven't done a lot of the same bills that other states have. So as we know, Texas has their Governor Abbott, put forward an order that said gender affirming care for minors is child abuse, which opens parents up to being investigated by Child Protective Services. There have been, bills in Florida, other states that have been similar. Florida health officials made an official recommendation to physicians across the state that said not to help minors transition, not even socially. So it was instructing doctors not to use minors' pronouns, their new names, anything like that. But to my knowledge, Oklahoma hasn't put any of these policies forward. I know that we have done the high school sports bans for people, trans people playing sports. We did reverse a new policy that allowed non-binary residents to change their birth certificates to opt out of the male-female designation. But to my knowledge, we haven't done any kind of legislation that would apply to medical providers who provide gender affirming care. But I could be wrong. I might have missed something, but I haven't written about anything that would affect that care.
All right, so this is Caitlin Mills, Engagement and Special Projects Reporter with KOSU. We're just hopping in here to talk to the folks who joined a little bit late. We're having this conversation about reproductive rights in Oklahoma, just an overview. And then we do have some room rules, just a few. Please be respectful of our speakers and of each other. Do not talk over each other, and please refrain from using any harmful or derogatory language. Also, ILA cannot give individuals legal advice. And so if you guys are new to Spaces, there is a request button in the bottom left-hand corner. So if you guys have a question you want to ask our speakers, just hit that button and we'll bring you back on. Allison, I'll hand it back over to you.
Great. So yeah, I think we're going to open up the floor to questions right now. I think let's see. There was one question in here that somebody asked about whether or not, since the Supreme Court has upheld tribal sovereignty, how would this? I think Bob Paxton, I see you all on here. Why don't you go ahead and ask your question, because I don't want to bumble it up here. Hello.
Hold on. I think we need to unmute him. All right. Bob, I invited you to speak to your question that you had messaged on Twitter. Bob, can you hear us?
Oh.
There.
Oh, go ahead. Sorry.
Yeah, we can hear you, Bob. Go ahead and speak.
Okay. I was just curious if, since the Supreme Court had already established that the tribal sovereignty is still in effect, how that would affect any consequences or any differences in the reproductive rights that they've that states and the Supreme Court has brought up recently.
Well, I think when we're talking about in terms of reproductive care and abortion rights, I think tribally run clinics and Indian Health Service clinics are only able to provide abortions in a very limited in very limited circumstances, when the woman's life is in danger, when she is a victim of rape or incest. And I will say that if you are a victim of a sexual assault and you become pregnant, there is an additional layer that you have to go through when you seek abortion care through an Indian Health Service facility, and that is that you must provide a police report, and you must have reported that within 60 days of it happening to be eligible to be able to get that to be able to get an abortion. And there's some inconsistencies in IHS policies and the Indian Health Manual, and then on what they have on their website. And I've asked, I've emailed in Indian Health Service here in Oklahoma and asked about that. So the Hyde Amendment applies, even though there is, even when we're talking about tribal sovereignty, the Hyde Amendment applies, because at Indian Health Service facilities and tribally run facilities, in order to be able to get abortion care. So the other thing I wanted to address too was just the availability of Plan B and the availability of contraception. Just until recently, actually, Indian Health Services was really inconsistent on their offering of Plan B over the counter at their facilities. I think it was Sharon Asatoyer who she is a she's a nurse, and she is involved with the Native American Women's Health and Education Resource Center, and she's been rallying for a number of years for a Native women's legal right to Plan B through Indian Health Service. And I have heard from some individuals in Oklahoma that Plan B is still difficult to get, even though uh, Sharon Asatoyer and Pamela Kingfisher, another advocate for accessibility of Plan B, from the Native American Community Board, which runs that Native American Women's Health and Education Resource Center. They have filed a Freedom of Information Act request. They've lobbied on behalf of women to be able to get greater access to Plan B and over the counter for Indigenous women at IHS clinics. So that's another barrier. So I just wanted to point that out. Sorry for taking over. And any other questions here?
Hey, Allison, I'll read the one that we got also in earlier. How likely is it that we will see additional restrictions on contraceptives passed in Oklahoma? Does the Oklahoma legislature have the same appetite for that as these other states? And what's the youngest age girls should get an IUD in case it becomes illegal?
That, I think, really follows off of what Allison was talking about pretty well. So I've been looking at that as well. Oklahoma has not kind of pitched the same kinds of things we've been seeing in Missouri and Louisiana and Tennessee. There have been lawmakers who have specifically and explicitly talked about wanting to limit Plan B and IUDs. So just a little bit of a primer on that. And I know this is a little bit elementary, so sorry if this is boring to anybody who studies a lot of sexual health. But when when sperm fertilizes an egg, that happens in the fallopian tube, and so fertilization happens there. Then that that fertilized egg has to travel over to the uterus and get implanted in the lining of the uterus, and then that pregnancy starts. So IUDs, those are intrauterine devices. Those are implanted into a patient, and they work by doing a few different things. So they make the doorway that sperm use to get over to those eggs harder to get through. They slow the sperm down, so it makes it less likely they'll reach that egg, and then it makes the lining of the uterus thinner, so it's a little less likely that it'll implant. Plan B, similarly, it makes it less likely that the sperm can get to the egg to fertilize it by making it less likely the egg is available. And then it also kind of makes that lining a little bit harder for a fertilized egg to implant into. So there are people who criticize these medications because they philosophically believe that life begins when that sperm and egg join, not when they implant in the uterus. So they're trying to criticize these medications that would not allow a fertilized egg to implant. So, as I said, there are some bills and some pushes to outlaw or make Plan B and IUDs less accessible in those states, but Oklahoma hasn't specifically done that yet. As of this week, I've been reaching out to lawmakers about whether there is that appetite. I think that's a great question. It's one I don't have an answer to yet, unfortunately. All I can say is that the legislature did consider a bill earlier this year. It died, but the only contraceptive specific bill that they did consider would have required minors to get their parents to sign off on any kind of contraception, which would include implants like the next one on that goes in your arm, other implants like that, IUDs, kind of pretty much any contraception. And the reason for that was a news story um, about one girl who ended up going to a youth services organization and getting an IUD without her mother knowing. Her mother lodged a complaint. That somehow turned into a myth about Tulsa schools taking a literal busload of girls and shooting them up full of birth control. That did not happen. But yeah, that bill ended up not making it through the process this year. So far, we've not seen successful legislation in that arena, but I'm not sure whether there is an appetite for it. But I am reaching out to lawmakers in an effort to figure that out.
Thank you, Catherine. We just got this other question from Tamia Cox Torre. She says, listening in on this great panel, I think there's some confusion regarding licensing, providing abortion care. The providers are not licensed to perform abortion. Is it the facility that must be licensed as a specialized hospital to perform an abortion? I guess Isla or Catherine, do you want to weigh in on that question?
Well, I'll just say briefly, and then happy to pass over to Catherine. When I was referring to licensing, I was talking about provider licensing. So primarily states engage in licensing of nurse practitioners, physicians, and it varies state by state, nurses, and there's literally dozens, if not hundreds, depending on the jurisdiction, of different providers. And so it's about the scope of your license and whether the kind of care that you're providing, if it is criminalized, could potentially lead to disciplinary issues in terms of maintaining your license. The other piece that comes up is in the context of liability. And so if you are providing care as part of the ITU system, you are going to be getting liability protection through federal law. And that's not going to be the case in terms of a provider not operating, or even, for example, a tribe not providing care as separate from its 638 and segregation of federal funds. Now, there's been some discussion of tribal licensing, and for a variety of reasons, there are very few tribes that have engaged in healthcare provider licensing. And some of the early examples that we do have were as part of a federal program for community health aid program that was still tied to federal law and provided restrictions in terms of jurisdiction between states and tribes. And so the Swinomish tribe, for example, created, because they wanted to address oral health issues a few years ago, an education program for dental health aides. They wanted it separate from the federal community health aid program. And so what they had to do is they created an entire licensing code for the licensing process and maintaining your license for dental health aides that went through the tribe. And then they also had to create an entire code in terms of liability of those providers. And so the idea that to prevent, let's say, any risk of maintaining your license in the state of Oklahoma or someplace else, that tribes could be licensing providers, that is absolutely an option, but it's going to have to consider issues of, are you trying to create provider classification through a federal program? If you're not, then you're going to be needing a tribal code, likely a tribal code and liability code that's going to come into play, and a licensing process. And so that has been done. It's not done very often. And this also butts into issues of civil jurisdiction, I mentioned, because even if a tribe had asserted its sovereignty, passing this code, allowing the licensure of these providers, even encouraging or protecting their provision of abortion care within the tribal code, a state could argue and it could litigate that their state laws should apply even though it's an Indian country. And so they would be engaging what I talked about as this infringement preemption analysis that courts use, balancing the interest of the state versus the interest of the tribe, and whether tribal sovereignty would be infringed upon by allowing state to assert civil jurisdiction in the cases of licensure. So it's profoundly complicated and has lots of implications, not just for the provision of abortion care, but in the context of the legal underpinnings available in a tribal code and the federal test for determining who's going to have civil jurisdiction.
Okay, just want to hop in here. Hi, everyone. This is Kate Lee Mills with KOSU Radio. If you guys want to ask a question to the panel, there is a request button that you select. I think it's on your bottom left. So just reminding you guys that's an option if you want to speak up.
We have another question about miscarriages, and what about the concern about being criminally charged for having a miscarriage? Last fall, there was a case of a young woman in Lawton named Brittany Pula who was prosecuted for having a miscarriage because they prosecutors argued that her methamphetamine use contributed to the miscarriage. Therefore, she was eligible to be criminally charged. I think she's serving. I think it's a 7-year sentence. I need to fact check that. But I guess what does this new abortion law say about that? Catherine, I don't know, or Isla, if you wanted to answer that question.
One thing I just wanted to add to the Pula case is, if I remember correctly, the pregnancy and her situation, when the death occurred, it was before the legal cutoff for abortion.
Yes,
So
exactly.
if I remember correctly, if she had gone to an abortion facility, there would have been no concerns, but there was a concern. I mean, obviously she's in prison. She was prosecuted for that death. So I think that it seems to me, and obviously Isla's going to know better than me. Also, the other attorneys in this call would understand this better than I do, but it seems to me like these laws can kind of exist independent of each other. And I honestly, I don't understand the legal, mechanism behind the Pula conviction. I wish that my colleague Hannah France was in here. She's been working on that a lot, but I do know that there are concerns about abortions for people who the child would not be able to live outside of the womb. There are concerns that people would be forced to carry that pregnancy to term and go through a very traumatic birthing process only for the person to die afterward anyway. And there are concerns about people who do have miscarriages and who still have a lot of fetal tissue in their womb who maybe would not be able to get that removed. There have been concerns about that in other states as well. So I don't have a ton that's very intelligent to offer in response to that, other than just noting, that was well before the cutoff for abortion, and she was still prosecuted.
Yes, she could have faced a life sentence for the manslaughter charge, and she was offered a plea deal for 16 years, but then opted to go to trial, and then she was eventually sentenced to 4 years in prison, and she's now the last I checked, she was considering her appeals options in that case. I don't know if you had anything to add about miscarriages and being prosecuted for miscarriages under current Oklahoma law.
Yeah, so I do, and it's really independent of the abortion laws, in that you will see the criminalization of miscarriages in two different ways. In this case, as you mentioned, this was the use of Oklahoma's criminal code under a manslaughter charge. And so that's really variable in terms of states' law, in terms of whether a miscarriage when there's existence of substance use disorder particularly is going to be able to be charged as a homicide. And then also variability in terms of states and some tribes. I did some research on this a few years ago, and that have laws that criminalize substance use disorder use during pregnancy. And so there could also be laws on the books that allow criminalization in that regard, or punishment outside of criminal penalties. For example, in the wake of opioid use disorder crisis and increased rates of opioid related overdoses, we saw several states pass more laws that implicated custody and family law arrangements for folks that used substances while pregnant. And so there's a variety of mechanisms. And I would be curious to see how that issue gets overlaid with some of the language of some of these criminal abortion laws.
Did we have any other questions right now? You can just, I think, request to ask us a question, and I think we'll be able to try to do our best to answer.
While we're waiting on another question, I just wanted to. Did we get one?
I think Connie.
Yes.
Connie might have a question. Connie,
Great.
you unmute yourself. You can speak.
I requested to speak a while ago, but I think I got, then I couldn't hear anybody, so maybe this has already been answered. I was concerned or wanting to have some information on all, the different types of miscarriage, misabortion, retained fragments. What protections will physicians have in emergency situations such as that, whether it was a self-induced or an elective procedure someplace else? Are there any information on that? And I'm going to pronounce this correct, but the misoprostol non-invasive effective method for complications of abortion, with a sublingual or vaginal dosage. Does anybody have any information on that? And what protections will physicians have in these situations, those gray areas of whether or not somebody, whether it's self-imposed or accidental?
That's a really
in
good
emergency
question.
situations.
Sorry, I didn't mean to. That's a really good question. I think, I don't know, Catherine or Isla, what protection will physicians have?
I don't know about Isla, but I think that it's really hard to say right now because we're just in a very different world than we have been before. I know that for my coverage, what I'm doing is looking to Texas because we have a copycat of their legislation, but it's still pretty new there. So there are a lot of hypotheticals that are still hypotheticals now. It's probably not a very helpful answer. Maybe Isla could help significantly more than I am. But as far as my answer goes, is I think there's it's just a we don't know on a lot of things for now.
Yeah, I honestly don't have I don't have much to add to the very real and important question is, let state legislatures have the option to add more protections, whether it's for the provider or the person who miscarries, and oftentimes they don't provide them. And so if, especially in the context of criminal law, when you have discretion of prosecutors in terms of charging and pursuing charges, it's just really hard to say how this is all going to pan out. But I also think if you read the language of some of these pieces of legislation, the idea is to not provide protection, and that's the goal. And so I too wonder how these statutes are going to be used moving forward.
Is there a way? I'm sorry.
Go ahead. Sorry.
I was just going to say then, is there a way? It just seems that there's going to be two definitions for murder, one for McGirt and one outside of that. And how do you separate the definitions of that case law?
Isla, you want to take that one? I think that is going to be have to be our last answer, and then I'm going to have to turn it back over to Kate Lee here. But like I said at the top of the like we said at the top of this conversation, any question we can't answer here, we will take it and try to answer it later on. And you can check KOSU and see check our coverage and to see if we've answered your question.
Thank you.
Yeah, thanks, Connie. So my thought on this is, and Allison, you'd asked me this question, and I'm not sure I answered it directly in terms of McGirt and reproductive health. The McGirt decision was specific to reaffirming reservation boundaries that had been ignored for a very long time. And that mattered in terms of criminal law, not because it reinvented criminal jurisdiction in Indian country, jurisprudence that has already been on the books and has been on the books for a long time, but because what we understood Indian country to be had shifted because of the reaffirming of previously ignored boundaries. Now, this idea of there's different definitions in terms of McGirt, what McGirt does is that it shifts in terms of who's going to have criminal jurisdiction. And so you might have the feds, the tribes, the states. And that has always been true when we're talking about criminal jurisdiction in Indian country. It's about shifting who is going to be able to prosecute. And so, yes, absolutely, you're going to have different laws that are applicable in the context of federal criminal code, in the context of tribal criminal code, in the context of state criminal code. But that's always how it's been. It's just a little different now because we are looking at post-McGirt, very, very large land base, and then a very, very large native population. And so volume has shifted. And that is also going to lead, as we've seen, more challenges to the law, especially in the context of Oklahoma that is resisting the McGirt decision at every turn.
Thank you so much.
Thank you so much, Isla, for answering that question, and thank you, Catherine, also for joining us to for this really lively discussion. We're almost out of time, but I wanted to jump in here before I handed it over to Kately and say that I am just starting a series of stories about reproductive care in Indian country, and this is everything from getting regular checkups to maternal postpartum care to how easy is it to access Plan B, and including doing some more reporting on abortion in Indian country, and then also looking at the Indian Health Service and some of its history in these areas. I just wanted to point out, Stacey Leeds tweeted something out. She's a law professor, expert in this area of Indian law, and she pointed out that Indian Health Service has a history. In the 1960s and 70s, Native American women accused Indian Health Service of sterilizing at least 25% of Native American women during that time between the ages of 15 and 40, between the ages of 15 and 40 during the 1970s. So that, again, that's another complicated and really terrible history that adds that I think is important to have in this conversation when we're talking about reproductive rights of Indian women and their voices being heard on this subject. So I'll be doing some reporting on that, and I'd love to talk to you as that goes on. So I'm going to turn it over to Kately, our host. Thank you.
All right, everybody. Thank you for those who joined the conversation today. We'll post an edited version of the recording online at kosu.org for those who want to listen to the discussion again or who would like to share it with others. Also, for those of you who we were not able to take questions from, please contact either me or Allison. My email is Kately, KATELEIGH @kosu.org, and Allison's is Allison, LLISON at KOSU.org. And you can also follow Isla at Isla Haas. You can follow Allison at Allison with one L, AHER. And you can follow Catherine at Kath J. Sweeney. And follow us at KOSU.org. Thank you guys.
Thanks so much.